So the other surgical procedure where neuromonitoring is not routinely performed are tibial fibular osteotomy in lower extremity. So tibial fibular osteotomy are the procedures which are performed to make the correction in the bent legs for mostly pediatric and adolescent patients, but routinely they are not monitored. So blonde disease is an uncommon growth disorder. It is usually seen in children and adolescent. It's characterized by abnormal ossification of the medial aspect of the proximal tibia. So the tibia from the more proximal close to the knee joint, it has abnormal ossification, and which may result in bending of the knee. The other terms which are commonly used are tibia vera, osteochondrosis, deformed tibia, um, are used to describe the blonde disease deformity. So the most common pathology cause of genovarum in children and adolescents is blonde disease. Tibia vera is classified into different categories. The first category is the infantile tibia vera, and typically seen in patients with less than 4 years of age. And then we have juvenile tibia vera, which occurs between age of 4 to 10. And the third one is adolescent tibia vera, which is seen after the age of 10. So this is a progressive deformity, and patient present with varus angulation due to internal rotation of the proximal tibia immediately below the knee. The result is bone growth abnormality due to irreversible pathological changes. We can see in this picture that patient on the left side, patient has blonde disease of the bone, and the knee, they don't touch each other, and um, they are space more, and so as patient has a difficulty in walking. So patient is diagnosed either with the tibia vera, blonde growth disorder of the shin bone, and or juvenile osteochondrosis, which occur in characterized by interruption of the blood supply. So when there's an interruption of the blood supply to the bone, especially to the epiphyses, which are the joint at the ends of the long bones, and then there's ischemia to that, and then it's followed by bony necrosis and regrowth of the bone. And genovalgum, also known as knock knee, is a condition where the knee angle is in and touch each other when the legs are straight. So there are different types of treatment available for these patients, and it depends on the age of the patient and the severity of deformity. The most common the braces are most commonly used for the patient with 2 to 5 years old, and surgery is not recommended if the patient is less than 2 years. Orthotic device is also ineffective in corrective adolescent varus, so patient with adolescent tibia vera, the orthotic devices and the surgery may be the only option. The surgical goal is to relieve the pain and correct the limb alignment, and a significant deviation from the normal mechanical axis may result in knee pain and osteoarthritis. So when these knees they are not straight and they are bent outward or inward, they will cause more stretching and pain in the knee. So and so the goal of surgery is also to relieve that pain beside the lining. There are different type of procedure for these osteotomy that are usually done depending on the level of the osteotomy, and sometimes the tibia and fibula, the osteotomy is not always done at the same level, maybe at a different level. So there's an opening wedge, there's a closing wedge, there's spike, oblique osteotomy, medial plateau elevation, and combination of different method. So a wedge, because when you're trying to the tibia is bent or fibula is bent, you want to straighten it, you have to make a wedge and take the part out to make it straight, to make more space. The treatment can be non-surgical or surgical. The non-surgical are typically the knee, ankle, foot prosthetic, and surgical are corrective surgery, which is tibial osteotomy. The complication is a patient who went under the proximal tibial, so it could be proximal or distal osteotomy. The proximal osteotomy is more related to the foot weakness or foot drop, because the common peroneal nerve is very close to that area and making arch next to the head of the fibula. Paper published by Gibson in '86 reported that the incidence of neurological deficit ranged from 2% to 20%. The postoperative deficit following high tibial osteotomy may not be transient, and it may result in permanent damage. And Wooten published paper that said that these deficits could be as high as 20% also. Another study, paralysis of the extensor hallucis longus muscle was common complication in patients with proximal tibial and fibular osteotomy. So the complications are presented as pain over this dorsal surface of foot and ankle along with the muscle weakness. So patient can wake up with a muscle weakness, but also pain over the dorsal surface of the foot and on the ankle. Um, the site of the fibular osteotomy is directly related to incident of postoperative peroneal palsy. So depending where the osteotomy is done is directly related to the risk of the peroneal palsy. The proximal has more higher risk. So another paper published in 2010, 23%, 23.6% proximal half compared to 3.2% or distal half. So the incidence rate of weakness or foot drop was about 23.6% when it was done in the proximal half of the tibia, and to 3.2% when it's done in the distal half of the tibia. So previously, neuromonitoring is not routinely performed in tibial osteotomy, and in order to identify and see the benefit of that, we decided to do surgery and do monitoring in 18 patients. And it started as I was one day long time ago. I was sitting with a pediatric surgeon, and we monitored scoliosis case. After this scoliosis case, so I had discussion with him in the doctor's lounge. We were sitting and talking, and I asked him what is this case, and he told me he's a tibial fibular osteotomy. And that was the first time I heard about that because we were not monitoring. And I asked him, do you have any post-operative deficit in these patients? And he told me like 50% of the patient wake up with a foot drop sometime. I was surprised to see. I said, wow, that's a lot. 50% is a big number. So I said, we can monitor that. If you want, I can monitor and see if we can make a change. And so he was surprised. He said, can you monitor these cases? I said, sure, we can do that. So we monitor the next case, and we have a change in posterior tibial common peroneal nerve and MEP, but no change in tibial SSCP. Surgeon was informed. Surgeon make the correction. And it was the peroneal nerve trap into the wedge, and he removed that, and signal came back. So the surgeon was happy, I was happy, and we decided to start monitoring every single case. So we ended up monitoring 18 cases before we published the cases in the paper. So we did a multimodality monitoring because when we combining all of those, so these are the just orthotic devices with how on the left side we can see the X-ray of this patient, and their alignment is like totally off. And on the right side, the first picture, patient has one leg, and then the orthotic device was placed, and then when it was removed, it was so the surgery is done with the braces to make sure the patient doesn't cause any damage to the healing bone. So we I published this paper in 2013, and you're welcome to collect more data and publish a bigger study because this is a very short study. So we monitor ulnar SSCP, tibial tibial and peroneal SSCP and MEP in this procedure and spontaneous EMG. And the bigger concern was damage to the common peroneal and the tibial nerve. So typical anesthesia was propofol total intravenous with propofol and remifentanil, no anesthetic agent, inhalation agent of nitrous oxide. And the death was 0.2% at the induction, but then it was stopped. and muscle relaxation was monitored by trainer 4 in foot muscle. So it's a multimodality with SSP, EMG, MEP, and trainer 4. So this was a preparation. So in these cases, the setup is done. Sometime you have to hand over sterile needles. So make sure you have needle pack which are not open, because you have to give it to the nurse and circulator, and then they open on the surgical feet, or surgeon or resident, they place the electrode after prepping the skin. If you're lucky, you can place the electrode and put a big tegaderm on top of that, and then the surgeon can prep above that. But sometimes you have to tell the surgeon. And in the middle picture, so we can see the two mark, and one is the upper one is the incision site for the tibia, and the lower one is for fibula. Here we can see the same thing, white arrow showing the tibia and fibular osteotomy site, and the black arrow, they're stimulating for the peroneal nerve on the dorsal. So the ideal stimulation site for peroneal nerve is head of fibula, but the surgery is done at that level, so we cannot stimulate. So we are stimulating from the dorsal surface of the foot. So this is the X-rays, intraoperative X-rays, and then making the osteotomy and placing the rod. So once the rod is placed, and the rod is placed before, after the osteotomy is done and the bones are aligned. So the surgical steps are post-induction baseline, then we do exposure, place the tourniquet. The tourniquet is done to minimize the blood flow, but sometimes too tight and may result in loss of your signal. So monitoring can be very helpful to know, because if you are not monitoring and blood flow is very, very low, it may result in ischemic changes to the leg. So the then tibia or fibular osteotomy is done, then the correction is done, and the placing the rods. Closing. In our study, we have 78% males, 22%, 78% females, 22% males, and we have left side in 72% patient, 6 bilateral, and 22 on the right side only. We have different age distribution these patients, and we monitor multimodality SSCP, and we can, one thing you can notice, we have cortical, subcortical, transcortical, then we have subcortical and lumbar potential. So last two, these two channels, they are subcortical lumbar potentials from peroneal nerve and posterior tibial nerve. So lumbar potential are very, very important, as I mentioned earlier, because they are very stable and they are not affected by anesthesia. So you can monitor them. And when you're monitoring them, so you have to place multiple electrode, because we don't know which one will be the best one, and you can choose one of them. So typically you do T11, T12, L1, L2, and refers to iliac crest on the opposite side, not the ipsilateral, because that will be in site of surgery. And for the comparison, we we compare the amplitude of the ipsilateral lumbar potential divided by the contralateral. So the change should always be ipsilateral side. The ipsilateral drops more than 50%. You see 0.5 or more, then it's a 50% drop. If the ratio drops more than 0.5, that's a 50% drop. If both drop, that means there's something else is going on. So ratio will stay the same. So make sure you're not doing contralateral divided by ipsilateral, you're always doing ipsilateral. So this is a stack view of the lumbar potential and motor evoked potential from hand and all the muscles in the lower extremity, and trainer 4 for all the extremity, from the both extremity, lower extremity, and spontaneous EMG done. So that was the protocol, monitoring all the muscle. So in the results, so we have changes. We did intervention in 4 procedures, and these 4 procedures, in three patients, there was a entrapment of the peroneal nerve in the osteotomy side, and surgeon was removed the nerve and from the trapped wedge, and the signal came back, and the 4 patient, the tourniquet pressure was too high. So, and that resulted in ipsilateral SSP and MEP change. So once the surgeon was informed in the real time, and surgeon took the did the intervention, and signal came back, and none of these patients, 18 patients, have any deficit. So these are the 4 patients, the top 4 patients with changes. They are not in sequence. So the first patient, number 2, was the first patient actually. So we have change in peroneal and tibial, and the other 3 patients we have changes in all 3. And then 14 patients, we have no changes in any signal. So in summary for these patients, applying multimodality monitoring with posterior peroneal ulnar SSP, including lumbar potential and MEP, you can perform monitoring with high level of confidence and can minimize any postoperative deficit, which is at high risk from 2% to 50% in these patients.